This is a boring EM chalk talk on an approach to understanding outpatient antibiotic management of skin and soft tissue infections. This chalk talk was created as part of a Digital Scholarship Elective at the University of Toronto. By the end of this chalk talk, you should be able to list common skin bacteria implicated in skin infections, classify bacteria by structure, like gram stain and organization, describe the difference between methicillin-susceptible Staph aureus and methicillin-resistant Staph aureus, outline risk factors for community-acquired MRSA and hospital-acquired MRSA, outline general antibiotic treatment principles for MSSA and streptococci infections, community-acquired MRSA infections, hospital-acquired MRSA infections, and Pseudomonas aeruginosa infections. There are 5 take-home points from this chalk talk. 1. For streptococci and MSSA infection management, use cell wall synthesis inhibitors like penicillins and cephalosporins. 2. For MRSA infections, do not use cell wall inhibitors like penicillins and cephalosporins due to resistance. 3. There are 2 main types of MRSA, community-acquired MRSA and hospital-acquired MRSA, and known risk factors for each. 4. Do not use clindamycin if you suspect community-acquired MRSA due to the risk of inducible resistance. 5. Risk factors for Pseudomonas aeruginosa include burn wounds, infections following nail puncture, and infections associated with hot tub exposure. Pseudomonas infections require targeted antimicrobial therapy. To begin, in general, the most common organisms implicated in skin infections are streptococci, which are gram-positive bacteria in chains, and staphylococci, which are gram-positive bacteria in clusters. This is relevant to know, especially because if a specimen from the skin is sent to the lab for microbial analysis, sometimes an early preliminary read is available, which may mention gram-positive bacteria in clusters or gram-positive bacteria in chains, which can help you with your initial antibiotic management. There are 2 main types of staphylococci: methicillin-susceptible Staph aureus, which is susceptible to the effects of bacterial cell wall inhibitors like penicillins and cephalosporins, and methicillin-resistant Staph aureus, which is resistant to the penicillins and cell wall inhibitors. In general, for streptococci and MSSA infections, cell wall inhibitors work effectively. These antibiotics contain beta-lactam rings, which inhibit cell wall synthesis of the bacteria. Examples include penicillin V or G. To note, penicillin V is the oral form, and penicillin G is the IV form. There is no good way to remember this other than to remember it's probably the opposite of what you think. Another example is dicloxacillin, or amoxicillin clavulanate, which not only contains the beta-lactam ring in amoxicillin, it also has clavulanate that inhibits beta-lactamases that some bacteria produce to break down beta-lactam rings, making this a broader spectrum antibiotic. You can also use cephalosporins, including cephalexin or Keflex and ceftriaxone. You can also use fluoroquinolones, which cause DNA fragmentation within the cells. Examples include moxifloxacin, levofloxacin, and ciprofloxacin. If your patient has an allergy to penicillins, you may also choose clindamycin, which blocks ribosomal activity within the bacterial cells. For skin infections, it is imperative to understand if your patient is at risk for MRSA infection. As you remember, there are 2 types of MRSA: hospital-acquired MRSA and community-acquired MRSA. Within MRSA, you need to consider how the person may have contracted MRSA. Was it in the hospital or in the community? Risk factors for hospital-acquired MRSA include recent hospitalization, long-term care placement, recent antibiotic therapy, especially if there was no full resolution of symptoms after the first round of antibiotics, and hemodialysis patients. In terms of community-acquired MRSA, the risk factors include HIV infection, men who have sex with men, injection drug use, unsanitary or cramped living conditions, incarceration, military service, sharing sports equipment, and diabetes. It's important to consider these two categories separately when considering antibiotic choices, because you do not use clindamycin if you suspect community-acquired MRSA. If you do, there is a chance of inducible resistance to clindamycin. For MRSA infections, we know that MRSA is resistant to methicillin. And since methicillin is a beta-lactam derivative, cell wall synthesis inhibitors are ineffective in treating MRSA. We therefore have to target other organs in the bacterial cell. Septra, or TMP-SMX, or cotrimoxazole, inhibits folate synthesis and metabolism. Doxycycline and clindamycin both inhibit protein synthesis by blocking ribosomal activity. With respect to treatment principles of cellulitis and skin and soft tissue infections, cellulitis can be grouped into cellulitis with abscess or purulence, or without abscess and purulence. Each of these groups are split into mild, moderate, and severe infections. The specific criteria and antibiotic treatment guidelines for outpatient management of skin and soft tissue infections are available on Boring EM as part of the Diabetic Foot Pocket Card, as well as the skin and soft tissue pocket cards. There's one special consideration that we want to highlight, and that is infection with Pseudomonas aeruginosa. Pseudomonas aeruginosa is a gram-negative bacillus that, due to its multi-drug efflux pumps, is resistant to many types of drugs. You should suspect pseudomonal infections in burn wound infections, infections following nail puncture, i.e. stepping on a nail through your shoe, or infection associated with hot tub exposure. Pseudomonas infections are usually associated with a characteristic blue-green discharge and are said to have a fruity odor. For management of infections that have risk factors for Pseudomonas, there are only a limited number of antimicrobials available due to the multi-drug efflux pumps. For your information, effective antimicrobial agents for Pseudomonas aeruginosa include most of the big guns. In terms of cell wall synthesis inhibitors, we have piperacillin tazobactam, ticaracillin clavulanate, ceftazidime, and cefepime that work on the cell wall. Fluoroquinolones that fragment DNA, including ciprofloxacin, are also effective. Carbapenems like meropenem and imipenem are also effective against the bacterial cell wall. While it is not imperative to remember all of these antibiotics, it is important to remember that if you suspect Pseudomonas aeruginosa infection, you need to target your antimicrobial management effectively. Going back to some more treatment principles for skin and soft tissue infections, depending on local MRSA prevalence, you may or may not include empiric MRSA coverage for skin and soft tissue infections. Areas of high prevalence of MRSA may recommend coverage. Always refer to your local antibiograms to guide your choices for clinical care. Susceptibility of various organisms may vary due to local resistance patterns. To summarize, the 5 take-home points from this Chalk Talk are: 1. For streptococci and MSSA infections, use cell wall synthesis inhibitors like penicillins and cephalosporins. 2. For MRSA coverage, you cannot use cell wall synthesis inhibitors due to resistance. 3. There are two main types of MRSA, community-acquired MRSA and hospital-acquired MRSA, and there are known risk factors for each. 4. Do not use clindamycin if you suspect community-acquired MRSA due to the risk of inducible resistance. 5. Risk factors for Pseudomonas aeruginosa include burn wound infections, infections following nail puncture, and infections associated with hot tub exposure. Pseudomonas infections require targeted antimicrobial therapy. To learn more, please refer to boringem.org, where you will find pocket cards for treatment and management of skin and soft tissue infections, as well as more information about diabetic foot infections, a diabetic foot infection pocket card, and sample cases to help you learn more about diabetic foot infections. This Chalk Talk and Digital Scholarship Elective was supported by the University of Toronto under the guidance of Dr. Teresa Chan at McMaster University and Dr. Andrew Petrosoniak at the St. Michael's Hospital, Toronto.